Hello everyone, welcome to my channel Ravi Static Physio. So in exercise therapy, the goniometric measurement, let's demonstrate the bony landmark where we can measure the range of motion of the particular joint. So the first is bony landmark of goniometer is to be, which is very essential for any physiotherapy to assess the range of motion of particular joint and where is per patient position in goniometer fulcrum position, where is to be a stationary arm position and moving arm position. So let's we take the first joint is to be shoulder joint. And in shoulder joint, let's demonstrate inflection and extension. In flexion, the patient position is to be supine and fulcrum is placed over the lateral side of the greater tubercle of the humerus and stationary arm is parallel to the axillary line of the thorax and movable arm is to be lateral midline of the humerus towards the lateral epicondyle. So it can be measured the shoulder flexion range which is 0 to 180 degree. And if you want to check shoulder joint extension range, the patient position is to be prone and make sure you have to be stabilize the scapula because it's to be compensatory movement will be occur if scapula is to be not stabilized. And in supine position, scapula will be stabilized by the plinth or a bed, but in prone position, scapula is freely movable. So you can stable by your hand or other things. So there is no compensatory movement will be occur. Fulcrum is same lateral greater tubercle of the humerus. Stationary arm is to be same parallel to the mid axillary line of the thorax, and movable arm is to be lateral midline of the humerus towards the lateral epicondyle is to be same. Next, in shoulder joint, abduction movement. In abduction movement, patient position is to be supine, and in adduction movement, also the patient position is to be supine. But fulcrum position is to be both are same anterior aspect of the acromion process, and stationary arm is to be parallel to the midline of the sternum, and movable arm is to move with the anterior midline of the humerus toward the medial epicondyle. Internal rotation and external rotation. Make sure patient has to be supine and you have to be slightly 90 degree elbow flexion and 90 degree shoulder abduction. So the patient position is to be supine, shoulder and elbow is to be flexed 90 degree. Fulcrum is placed over the olecranon process and the stationary arm is perpendicular to the floor because you have to be plinth, your hand is to be edge of the plinth, your elbow joint is to be edge of the plinth, and let's suppose that it is perpendicular to the floor and movable arm is to move with the either is to be external or internal rotation. So is to be it is parallel to the stylet process. It will be moved with the ulnar stylet process. So you can identify the range 0 to 90 degree is to be external or internal rotation. Next, coming to elbow joint, flexion and extension. Basically, it will be occur in elbow joint. Patient position is to be supine. Either you can sitting, you have to measure, but the fulcrum position is to be lateral epicondyle of the humerus and the stationary arm is to be lateral midline of the humerus and movable arm move with the midline of the radius. So you can easily measure the range of the elbow joint. Flexion range is to be 0 to 140 degree and extension is to be 140 to 0. Next is to be wrist joint. Wrist joint in flexion and extension. Both you have to measure, the patient have to be sitting, forearm is to be supported because if there is unsupported, there is compensatory movement will be occur. Lateral aspect of the wrist, trichotrum, which is bone which is present in our wrist joint, carpal bone, and the stationary arm is to be stable midline of the towards the ulnar oncoron process. Also, the movable arm is to move with the fifth metacarpal midline, lateral midline of the fifth metacarpal, which is here, fifth metacarpal, and the radial or ulnar deviation. Radial deviation or ulnar deviation, patient position is to be sitting, forearm pronated, and fulcrum position is to be dorsal aspect of the wrist capitate. Capitate bone is present in our carpal bone. And the fulcrum is to place over the lateral aspect of the wrist trichotrum, which is here, and the stationary arm placed over the lateral midline of the ulnar towards the olecranon process, like radial and ulnar deviation. Dorsal aspect of the forearm in between the radius and ulnar, which is here in introsseous membrane. Movable arm is to move with the lateral midline, dorsal aspect of the third metacarpal, which is here. This is third metacarpal, and it is will be moved radial ulnar deviation or radial deviation. So it will be moved with the movable arm. Pronation and supination. So you have to be measure the pronation and supination in the sitting position. Elbow is to be like 90 degree and fulcrum is placed over the ventral dorsal aspect of the carpal bone between. It means you have to be check like hand is to be neutral position and the fulcrum is placed over behind in between the dorsal aspect of the carpal bone, which is here, and or also the stationary arm is perpendicular to the floor like this, and movable arm is moved with the hand like that, and after that you can move your hand, and after that moving arm is to be moved over there. So across the dorsal pronation, volar supination aspect, the forearm proximal to the stylet process is to be moved. Next, our lower limb. Next is hip joint. In hip joint, there is a flexion and extension. So you have to measure by supination, inflection, and fulcrum is placed over the greater trochanter, and stationary arm is to place the midline of the pelvis parallel to the trunk, and moving arm is to lateral midline of the femur. In extension, change the patient position is to be pronation, and adduction and abduction both you can measure in supine position. Fulcrum is to place over the ASIS, which is anterior superior iliac spine, the measuring side, and the stationary arm is line joining between two ASIS, and moving arm is to be moved with the midline of the femur towards the patella bone. So you can measure abduction and adduction of hip joint. Internal and external rotation you can measure by the sitting, and hip and knees joint is 90-degree flex. Fulcrum is placed in the center of the patella, perpendicular to the floor, which is a stationary arm. Moving arm is to be midline of the tibia towards the ankle joint, and move with the ankle tibia. I have to check internal or external rotation. So if patient is sitting on the table, so if there is movement of the tibia, so we can measure internal and external rotation. Next, come to the knee joint. In knee joint flexion and extension, you have to check patient position is to be supine, and lateral fulcrum is to be placed over the lateral epicondyle, and stationary arm is to midline of the femur towards the greater trochanter. Movable arm is to move with the fibula towards the lateral malleolus, because fibula is present in our lateral side, so you can easily measure with the range accurately with the flexion and extension in the supine position. It is accurately, which is coming 140 0 to 140 degrees to be flexion, and 140 degree to 0 degrees to be extension. Next is to be ankle joint. In ankle joint, motion is to be dorsiflexion and plantarflexion all being incurred. So patient position is to be supine, sitting, knees flex 90-degree. Fulcrum is a lateral placed over the lateral malleolus, and stationary arm is to be parallel to the towards the fibular head, and movable arm is to move with the fifth metatarsal bone. So you can easily identify the range checking over the dorsiflexion and plantarflexion of the patient. Inversion you have to be patient position is to be prone position and foot over the edge. So you can check the eversion into the edge position of the leg or to the foot, and also the fulcrum is placed over the posterior ankle between two malleoli, and stationary arm is to be midline of the posterior leg, and moving arm move with the calcaneum bone. Next is to be cervical spine. Cervical joint you have to change the flexion extension. Patient position is to be sitting, and fulcrum is placed over the external auditory meatus, which is outward part of the ear, and stationary arm is to be perpendicular to the ground, and moving arm is to base of the nares, which is present in our nose tip. So you can easily find it out the flexion and extension range of the cervical spine. Next is to be lateral flexion. Lateral flexion in patient position is to be sitting. Fulcrum is placed over the spinous process of C7. Perpendicular to ground is to be stationary arm, and moving as move with the midline have the occipital protuberance. So you can easily measure the lateral flexion of the cervical spine. Next movement is to be rotation. You can measure the cervical spine. The patient position is to be sitting. Fulcrum is the center of the head, which is tip of the head. You can prominent area you can overplace over the fulcrum. And next is to be stationary arm is to be move with the parallel to the acromion. Stationary arm is to be stable to the acromion process, and movable arm move with the tip of nose into the rotatory movement. So also you can stationary arm and movable arm is placed over the like that one upon the over, and during the movement you can stationary arm is to be stable over the nose tip, and movable arm after the head rotation. After that you can move the moving arm of the goniometer. Next is to be thoracolumbar joint, thoracolumbar spine. You can check the flexion extension. Patient is to be standing, shoulder width apart, pelvis stabilized. Fulcrum is to be in between the ASIS or PSIS or iliac crest. Either you have to measure with three things. Next is to be stationary arm is to be perpendicular to the floor or vertical. Movable arm is to be along with axillary line of the 12th rib, or also the lumbar or also the spinous process over the roof. Next is to be lateral flexion. You have to measure thoracolumbar spine is to be. Patient has to be standing position. Fulcrum is to be placed over the astos, which is sacrum or midline of the sacrum. Stationary arm is to be perpendicular to the ground or the vertical, and movable arm move with the spinous process, which is C7, and which is lateral flexion either into the left side or either into the right side. Rotation left to right. So patient position is to be sitting, feet flat, pelvis and stabilized. Fulcrum is placed over in between the two scapula, so you can easily measure the rotation of the thoracolumbar spine, and or center of the cervical aspect of the head. Next is to be stationary arm, imaginary line between iliac crest. You have to imagine then the line moving towards the either into the left, either into the right. So you can measure out into the in between the scapula, move into the right side. So you can move arm is to be moved with the with the scapula into the left direction of the right scapula, either into the right direction of the left scapula. A movable arm is to be visionary line between the acromion process of the shoulder. So you can easily find it out the thoracolumbar spine a movement of the rotation, either into the left side or either into the right side. Metacarpophalangeal joint. Is to be measured by flexion extension. Patient position is supine, pronation, pronated or neutral hand is to be stable, like that. Dorsal have the two metacarpophalangeal. Dorsal aspect is to be there. Metacarpophalangeal joint. And stationary arm is to be midline of the metacarpal, which is here. And movable arm is to be dorsal midline of the proximal phalanges, which is here. And you can check the range, either is to be flexion, either is to be extension of the metacarpophalangeal. Next is to be adduction and abduction. You have to patient position is to be sitting and pronated hand. Next, fulcrum is placed over the dorsum aspect of the metacarpophalangeal, like here. And stationary arm is to be midline of the metacarpal, which is here. And movable arm move with the midline of the proximal phalanx. So like proximal phalanx, you can check the range. It's like that. Next is to be proximal interphalangeal joint. So you have to easily find it out by your eyes without any goniometer, but you have to take in any goniometer, which is small goniometer. In flexion extension rate, patient position is to be sitting. Dorsal aspect of the proximal interphalangeal joint. Stationary arm is to be dorsal midline of the proximal phalanx, and movable arm is to be dorsal midline of the middle phalanx. Distal interphalangeal joint, metacarpophalangeal joint, you have to be find it out by your goniometer. It is written here. Flexion sitting forearm pronated. Fulcrum is to be dorsal aspect of the DIP joint, which is distal interphalangeal joint. Stationary arm is to be dorsal midline of the middle phalanx, and movable arm is to be dorsal midline of the distal phalanx. Metacarpophalangeal joint, there is a four movement: flexion, extension, abduction, adduction. Patient position is to be supine, ankle neutral, foot is supported in flexion extension. Fulcrum position is to be dorsal aspect of the metatarsophalangeal joint. Stationary arm is to be dorsal midline of the corresponding metatarsals, and movable arm is to move with the dorsal midline of the proximal phalanx. Next is to be adduction, abduction. Patient position is to supine and sitting in the neutral position. Fulcrum is placed over the dorsal aspect of the metatarsophalangeal joint, and stationary arm is to be stable with the midline of the metatarsal bone, and movable arm is to move with the dorsal midline of the proximal phalanx. So you can easily find it out the abduction adduction range of the particularly metatarsophalangeal joint. So that is the end of the bony landmark of the goniometer and end of the goniometer chapter. So you can here is the range of the particular joints. You can keep this thing joint ranges in your mind. So cervical spine, thoracolumbar, foot, subtalar and metallars, and ankle, hip, and fingers, elbow, and shoulder joint. So that is the goniometric measurement.